All right, I'll kick things off. Welcome, everybody. I'm Aaron Niederheiser, CEO and co-founder of Tuva. Really excited for this fifth community meetup that we have today. We've got Paul, who is our head of analytics at Tuva, presenting on a topic related to Outlier analytics. Should be really exciting. Just a couple of housekeeping things before we dive in. One, what's the goal of the meetups? Really, we think the goal of the meetups is just to learn something interesting about healthcare analytics. There's so much kind of domain knowledge that's required to do healthcare analytics, right? You need a lot of data knowledge, you need a lot of healthcare knowledge to make sense of the data. And so generally speaking, you can be in the space for like 25 years and still learn something new every day. That's one of the things that's kind of interesting about it. And so we really try and make these an opportunity just to learn from each other. Two, we try to keep things pretty informal, right? So it's like if you have a question, I'll try and help moderate if there's questions. It can be difficult to present and like kind of field questions. If you have a question during the presentation, drop it in the chat and I'll try and moderate that and bring it to Paul's attention. Otherwise, we'll try and save some time for questions at the end too. But either is fine. This isn't a super formal thing. And then three, we're going to be doing a lot more of these this year. And if you want to see the schedule that we have in mind for what's coming up, you can go to the tuvaproject.com, and just along the top, there's a section called Community, and that'll take you to just kind of the ones we've done in the past, and you can find links to those recordings, or the ones we have planned for the future. We've got a really exciting couple of talks coming up. In 2 weeks, Coco and Brad are going to be going through a full library of predictive models that we've trained on Medicare fee-for-service claims data that we're going to be open sourcing. The models are like for risk adjustment and risk stratification. So that's our next one. It'll be, I think we've got that slated for July 9th. So I'll send out like sign up info on Slack and stuff, so you can see that, so that you're aware of that. I think that's all my boring housekeeping stuff. So with that, I will hand it over to Paul, and we can get going.
Sounds good. Thanks, Aaron. And thanks everybody for being here. I know these things sometimes are hard to pull away from your day-to-day job and sort of join something like this. So really appreciate everybody that joined. I'm relatively new to Tuva, so my name might not be familiar if you've been following the Tuva project for a while. I joined in March, and I came from a investment fund focused on value-based care called Valtruis, where I was basically their data and analytics executive advisor, supporting a whole host of portfolio companies that were doing value-based care. And pretty early on in that journey, I met Aaron and Coco and got to know the Tuva project, and I was like, where has this been all my life? This is exactly what I needed at all my prior roles. And just a little context on that, I'm an epidemiologist by background, and got my start in sort of the healthcare sector at Blue Cross and Blue Shield in Minnesota, and did a bunch of health economics type research, program evaluation, reporting, just all the things, using SAS, kind of an old school analyst. I think we had a mainframe, and had to change the tapes when we ran big jobs. So that was sort of the sleepy start of healthcare insurance. Then I went from there to Bright Health, so a startup health plan, and what I thought was bad data at Blue Cross turned out to be pristine. by comparison, because we had, dirty data from a bunch of different sources at Bright Health, and we needed to set up health plan functionality, which was basically cost and utilization analysis. Which cohorts do we need to be targeting? How do you manage, a health plan operations, and clean up claims data and do all the things that, we had done before. So we basically had to build that from scratch. I can't say we did an awesome job of it, but we got it working. And then from there, I actually went to a digital healthcare startup called Livongo, where they were doing, oh, my face is gone. My face has gone blurry. That happens to my camera, so apologies on that. Livongo is a digital healthcare startup, and they had a lot of success in the commercial market, but they wanted to sell the health plans. And again, it was, we need to be able to show our value and use our claims data in a meaningful way. But they didn't have any claims data model to speak of. So it was constantly like cleaning data so we could do analysis on one client, and then cleaning data so we could do analysis on another client. So the great thing about the Tuva project is, that problem that everybody has, it's like a good solution that enables analytics. And so one of the things that we're trying to do with these meetups, and now that the Tuva project has kind of reached a capacity and a set of capabilities that really is pretty great, is builds and showcase some of the capabilities on top of it. So now, you have the underlying data model that many of you, if not most of you, are probably data and analytics people, data engineers, analysts, data scientists, kind of know intuitively, oh yeah, I need a data model. I need to be able to like link to terminologies. I need to group claims together in specific ways. I need to handle reversals and denials. It's kind of obvious if you have tried to work with and analyze healthcare data. But many people don't understand the mountain of work that's kind of under the surface of the water. They just see the tip of the iceberg on top, and it's like, where's that dashboard? Where's that report? And so one of the things that I'm excited to do is spend some time showcasing and actually building some open source sort of analytics and reports that just show, oh, here's how you can do some of these types of analyses on top of the iceberg that the Tuva team has created to date. So that's the purpose of today. I'm going to get into some basic healthcare economics sort of terminology and some of those things. As a person who is not a data engineer or developer by background, I often feel overwhelmed or go on like Stack Overflow, and I'm like, they didn't start at the beginning, and I'm never going to be able to understand this. And so I'm kind of that person who has to start at the beginning. And so I'm going to go ahead and do that this time. And apologies to all of you where some of this may be maybe a little bit basic. I just think it's helpful to start from the basics and have this out there. But in showcasing, data and analytics on top of Tuva, we were thinking, what could we do for these community meetups? What types of analyses are interesting? And it's not very interesting to do these things as just an exercise or with a very niche problem that might be, applicable to, one company and very interesting to that company, but maybe not interesting across the board. Something I'm always interested in and thinking about, particularly in the context of any value-based care work that I've done in the past, is outliers, right? Like you ask your sort of basic questions about a given population, and it's like, what's driving cost and utilization? And are there outliers? Are there like a few members that are really driving most of the cost, and what's going on with them? And you could want to know about that for any number of reasons. If you're doing an analysis and you need to exclude them from the analysis for some reason, or if you're setting up a VBC contract and you need to like carve them out or figure out what you're going to do about stop loss or mitigate that in some way. Or if you have you might be only interested in high cost, high complexity members that are driving a lot of, cost on an individual level, because that's your clinical model. So it's just been an item of curiosity to me that seems basic. We all probably have like an idea of like, oh, what are the top 10 drivers of Outlier costs and what should we be thinking about for carve outs? But I didn't really know that. And I just wanted a way to kind of quickly and easily get to it. And so the sort of the purpose of this analysis and what I'll cover today is twofold. One, I want to step through some of the basics for how to analyze any cohort, against the Tuva model. And frankly, against any claims data set. You could have a different model that's not Tuva, and this would be applicable, if not plug and play. The nice thing about the Tuva model is it is pretty much plug and play. And so we'll kind of walk through, set up the analysis, some of the definitions, and then we'll get into the query. Man, I had a really nice notebook with annotated like queries and everything, and I lost the notebook, so I'll step into the query, but I'm not going to go into extreme detail because honestly I lost my nice annotated notebook, which I'll get back and publish. But and then we'll look at a Streamlit app that basically has a dashboard that just shows a couple things. One, like for any cohort that you're going to analyze, you kind of want to look at like the broad population, and so it shows how I typically like to look at it. And a lot of people like to look at it differently. And I love ideas about how to make this better or how you typically look at it or what's missing. But basically just like you're going to set the table with some context and then getting into a little bit of, okay, what is driving cost and utilization in these outlier populations? And then actually, I sort of expect this to be a series. So, there were some things that came out of this analysis that had me scratching my head and going, I'd like to do a deep dive on that, and I've already kind of started, but it's the topic of, like a whole other analysis and a whole other talk. So we kind of can sort of dig down this outlier rabbit hole together and maybe a series of meetups, but this is the first one. So I don't know if there's any questions that have come up so far, but
no questions in the chat so far, Paul, but I'll keep you posted.
Sounds good. I will share my screen here and dive in. I'm going to start with just a deck. So I talked about some of this already. I have to find where I have this deck here. Okay, so we're going to set the stage with what are some key metrics for cost and utilization analysis and claims. Some of this is basic, but some of it, when you're trying to set up BI or like create a flexible analysis, some of it's a little complicated and nuanced. And so in my experience, even though like intuitively I've been doing this for a while, it was one, hard to grasp and hard to kind of wrap my head around when I was first starting out. And two, like almost every time that I do an analysis, I still have to like think through some of the complexities of calculating PMPMs or costs per util or things like that. Then, as I mentioned, I'll get into the queries. I'll talk about kind of creating a population summary. So basically just setting up some context for the population you're looking at. And then the fourth and sort of final thing is like starting to identify key drivers through two different lenses. The type of service. So basically what's being done, what is the service rendered, and then what conditions people have. These are two common starting places, but I always find like looking through sort of these two lenses independently gives me a good sense of where to go next. And then after that, your analysis often starts to get more specific to your given population. Defining key metrics. The basic health economics, this is where it gets pretty basic. So if you're already an expert, health economist, this may be boring. You may look at this and say you're doing it wrong. Feel free to chime in if that's the case. But the basic cost equation is the total cost of something is in a basic economic sense is the number of units times the cost per unit. And so when we break that down in a healthcare context, specifically when you're analyzing claims, we typically express total cost, not in absolute terms, so the total dollars spent, but in per member per month. Most of you probably know that and are aware of that and are familiar with PMPM cost. I wasn't when I started, so I'm starting at the beginning. The Stack Overflow thing, you can kind of start here and get a sense of it. It's basically just the total cost, and cost in the context of claims, and I'm not going to get into this, is usually on an allowed basis, which is the total cost that was paid to the doctor, or a paid basis, which is the total cost sort of without the member share or the member accountability amount, like deductible and that sort of thing. You typically don't do billed charges, which is the amount the doctor charges. And it's very rare that you're doing an analysis on like the member share components or provider discounts. I'm not going to get into that. Assuming it's allowed or paid basis, what we have with our data is basically on a paid basis. So we'll just represent it as paid PMPM, but you could substitute allowed PMPM if you wanted, divided by the member months. And if you don't know, just to be very thorough, a member month is basically the number of months a member was eligible for a given plan in a given period of time. And then the corresponding sort of utilization and cost per unit measures are annualized utilization per thousand, and average cost per utilization unit. And these units can vary. They can be visits, they can be claims, they can be episodes. In our case, I'm going to use a Tuva concept called encounter, which basically takes a specific medical encounter, which could be a visit or an admission or whatever, but it actually lumps in sort of the professional and institutional components of that service into one sort of encounter. And so we'll be counting encounters. So one other nuance I wanted to spend a little time on, at the risk of really beating this to death, is PMPMs. I think there are different ways of thinking about and calculating PMPMs that I'm not even sure if there's terms for this. So I think Aaron once talked about contribution margin, and I stole the contribution part of that, and am calling this contributive PMPM. Whether that's a word or not, I don't know. But basically, you can have a PMPM that's going to roll up to the total amount. So you have, in this example, let's say you have 833 members. I think I got that by sort of deduction, in your population, and the total cost is $5 million. And those 833 members contributed a total of 10,000 member months for an annual period, for a year. Well, then you just take the 5 million divided by the 10,000 and get $500 per member per month. That's pretty straightforward at the very highest level. But then when you want to break that down by a service category or a diagnosis code or something, is where it gets interesting. So one way to look at it, and the way that I'll be looking at it in this analysis, and the way I typically like to think about it, is you have your population and you want to know specifically like what's driving care in this population. So of that 500 PMPM, how much of it was attributable to cancer or inpatient or whatever. And so that's obviously going to be some fraction of the 500 PMPM. And so the PMPM would then, like any PMPM for any subcategory, would be divided by the 10,000 member months from the highest level, even if you have like basically a slice of the dollars. So contributive PMPM, basically, if you have an inpatient spend of $2 million, you're still going to have in your denominator 10,000 member months, and so you'll get 200 PMPM. And basically, the key output of the contributive PMPM is PMPM costs that are distributed across a set of dimension or a set of categories or value sets that add up to the total 500 PMPM. It's nice and clean. It's an easy way to kind of look at the population. But there's another way to do it, which I'm calling relative PMPM, where you're actually taking, for that, maybe that same breakdown where you have like inpatient people who had an inpatient admission, they still incurred a $2 million cost, but you can actually subset the people in the denominator to only those that actually had an inpatient visit. And so maybe those members only contributed 2,000 member months, which means the PMPM on a relative basis for inpatient utilizers is $1,000. And that's a perfectly valid way of doing that if you're comparing two populations of inpatient users. but it doesn't help very much when you're trying to understand how much of an impact that inpatient cost is having on the total population. So for the purposes of this analysis, I'll be using what I've just explained as contributive PMPM. Again, not sure if that's a term or not. It's just what I'm using. If there's any questions on that, we can stop there. I think for most of this group, it was probably pretty basic and you're ready for me to move on. But if you do have questions, feel free to chime in or reach out directly. I'll go through these next ones pretty quickly. Utilization per thousand is another one I sort of sometimes have to wrap my head around, just because calculating it is not always, I think, intuitive. But basically, you're taking the utilization units, and again, this could be anything. It could be number of visits, number of encounters. In this example, I used visits because it's probably more common. And so thinking about that same population, we have 833 members contributing 10,000 member months. And we're going to standardize this in a couple of ways. One, you want to know, you have your utilization units, and that could be happening over a number of months or over the entire year, and you want to standardize it. So you want to know, like, how many units are being used per some number of members, and a pretty common number is 1,000. So you then can say, okay, well, in this population, we have this many visits per 1,000 members, and that's going to be on an annualized basis. So you're looking at it over the course of a whole year. And so the two sort of adjustments that you're doing here are your annualizing and your standardizing to 1,000 members. And that makes it comparable. So you can look at the annualized utilization per 1,000 in your population against some benchmark population or some target that you have or whatever, and it's typically standardized so that it's an apples to apples comparison. That's really all this is doing. And so the breakdown here is pretty straightforward. Assuming you had 5,000 professional office visits, you divide that by 10,000 member months times 12 to annualize it. So you're dividing by the number of member months, which gives you 5,000 office visits per member per month, times 12 gives you per member per year, and then times 1,000 gives you 6,000 visits per members per year, which isn't very intuitive to me. So I did it a different way, just so you can kind of see that actually translate. You could just do it for one member, and that translates to 6 visits per member per year. It's just often standardized to 1,000, which is that top number, and so that's what I'm sort of highlighting here.
And Paul, the convention for, I've always seen the per 1,000 convention, but it's just kind of a convention, right? We could do, as like industry just uses it, we could do, exactly, per 552, but that is not as intuitive.
That's right. Yeah, if you go to Milliman or some company and buy benchmarks, they'll give them to you in per 1,000, unless you ask for something different.
I mean, I'm glad you went through this, because it made me remember back to like 15 years ago now, when I was first learning this, and I actually remember having to write it out on, it just wasn't intuitive. Now for me, you've been around it so long, you're like, okay, 1 + 1 = 2. You don't even think about it. You just kind of know it. But I do remember I'm like, wait, what? We're trying by 12 and then 1,000. And it's kind of like high school science, where you're doing the units conversion, numerator, denominator. How do I go from milliliters to liters to grams to or whatever?
Yeah, and I particularly find it helpful to break down, because once you get it down, it's very easy to calculate and you start using it. But actually, if you're in the situation that probably many people on this call are, you're working with business partners for whom this is not intuitive. And so you might need to convert it back or explain how it's calculated. And I'm sure many people have many experiences doing that. So that's why I just wanted to sort of set the stage here, just for new analysts starting out. I think our community is fortunate to have a lot of people just getting going in their careers, or data engineers that might have come over from a different sort of industry. And so you're just trying to understand why things are done the way they are. That's kind of why I wanted to start at the beginning. The last one, and I know I'm already a half hour into this and haven't got into the fun stuff, so I'll go quick, is pretty standard. This is like completely the opposite. It's very easy. It's the total cost on an absolute basis. So if you have 833 members, $5 million, same 5,000 visits for professional office visits, and the same cost for that subsegment, so $2 million. You're basically just taking the total cost divided by the total units, whatever those units are. So it's and that gives you your per unit cost. Very straightforward. So those are the three metrics. And now I'll actually get into sort of building queries for cost and utilization analysis. And these metrics are important to kind of know about because we're trying to build some data sets that make it very easy to calculate those things. So this is actually, I'm going to try to get a little bit more specific on like the types of things that I would want to know if I was going to go start an analysis against the Tuva project. And if you're not familiar with the project or you're new to it, sometimes it's overwhelming. We have a lot of great functionality, a ton of data marts, a ton of tables. So when I started on this, even in the last couple of months, it's like, okay, well, what are the go-to tables? What ones should I use? My hope is that this helps you sort of walk away with a query and an idea about how to go just start an analysis that can get you pretty far against the Tuva model. And then you can build on top of it with all of our other great capabilities and things like that. So there's basically two core queries. One that's pulling claims data. And the claims data is going to give us basically utilization and cost. And then another is member months, which is a member months query is basically going to be include your demographic information and member information, but it's on a member, like one row per member per month they were enrolled, which makes adding up member months very easy. But your demographics and all of that stuff will be in this query, and we'll pull that from a few different places. I'm not going to go through the important fields just due to time, but we'll put this deck out and you can get the information there, and then the query will be available as well. The Tuva tables to use, we'll get into this too. We'll just provide this, but basically it's going to be in our, most of the really important data sets in Tuva are in our core data model, sort of the core schema, if you will. So when you load your data into the Tuva model, there's a schema called core. It has a bunch of tables in it. The key tables for this are member months, patient, which is going to have your demographic information, risk scores I'm pulling in here, and I'm not going to go through in detail, but I pulled them in for some context, and a lot of people like to have that when they do this type of analysis. Medical claim, obviously, and then pulling in some conditions and procedure categories as an optional thing from a couple of our value set data sets. So CCSR, which is just condition categories that are put out by the AHRQ, a lot of people are familiar with. And then Betos groups, which helps categorize a subset of procedure codes, which I'm not actually using that in this analysis, but I included it because it can be helpful at times. Okay, I'll jump into the query demo, but having gone through that, I might have saw a couple questions pop up. Aaron, are there any questions that I should pause and answer here?
Zach wants to know if the slides are going to be made available after. Yes. Yes, Zach, we'll make the slides available. Lalit proposed another term for relative PMPM could be per month per utilizer, where utilizers are those who have used a given procedure or seen a diagnosis. I have heard that before. Bogdan says, question for later, would be curious about your perspective on how you make health plan related measures more relatable and usable by providers. For example, primary care providers caring for a panel of 2,000 patients and their measures as related to clinical operational performance versus health plan style performance. So basically communicating, is there a difference in communication style if you're talking to docs versus health plan people?
Yeah. I definitely think there is, and I think there definitely is, and typically when you're communicating with physicians specifically, they're going to be much more interested in care gaps and some of the things that really matter for their patients that drive some of these downstream metrics. I'm not going to go into it further than that, although I forget that person's name. I'm happy to jump on the Slack or have a conversation about that, or have a conversation in Builders Ask around that. Or if it's interesting enough, we could get into it in another community meetup. So, but for the sake of time, I'll press on. It's a really good question though. Okay, I'm gonna run through this query. I'm really just still a little sore at Snowflake, which is where I pulled together this nice notebook that I annotated. So really apologies for having this query in kind of a mess, but basically, and we'll publish this query probably.
Oh, I don't see your screen anymore. I don't know if that's just me.
Oh, that's me. Thank you. So I'm going to walk through the query. I probably won't run it because I'm actually pulling this from Medicare LDS data. So the data that we'll be analyzing that's sort of meaningful today is we have Medicare LDS, basically a 5% sample of the Medicare fee-for-service data for 2020 members, or the 2020 year. So that's what I'm working with, just 1 year for this specific analysis. I think we recently have got some more, and so we probably can do this against another population. And so that's just to make it a real population and interesting to the group. We'll also be basically publishing a Streamlit app that has a dashboard in this query that you can run against our Tuva demo data. That is kind of less meaningful because it's synthetic data and it doesn't like the results. And I'll show both of those results. So basically, I'm going to kind of go through this relatively quickly, and then we'll put out the actual query. I think I've explained the concepts, but we have to pull the member months into a table. So basically right now what we're doing is pulling all data from 2020 for all members in the population, and we're just pulling that together in the structure that we want. So I'm pulling like person ID and member ID, and you can use each one, but I'm doing this at the sort of the member ID level. I'm not going to get into the nuances of that. Setting up some basic concepts such as the year. So the year month table is going to have like one row per member ID per year month, which will be in the form, 2020-01 for January or 2020-02. And so a member can have like up to 12 rows in the specific data set. I'm subsetting the year so that I can do this by year for, data sets that have multiple years. Pulling in demographic information. This is coming from our core.patient table, sex, race, state, stuff that's there that might be of interest. And then I'm pulling in risk score from our risk score, our CMS HCC mark, using CMS HCCs as the risk score. I'm not going to get into the dynamics of this specific query. You'll have it here. I've sort of checked it a couple different ways, and basically I'm using the unadjusted V24 risk score for those of you who are familiar with HCC risk scores. And so that's what I'm using, this raw one, actually, not the normalized one. And so pulling that together, this is a pretty straightforward query. I won't go into it in depth, but then pulling a medical claims query, kind of the same idea, cleaning up years, pulling in some key variables. Something to note, in this analysis, I'm going to be looking at a couple different things. So I'm pulling in some of the key attributes that we need. So claim ID, at this level, I'm pulling in claim line number, but I actually am going to get rid of that later on. Claim type is like institutional, professional, person ID and member ID. Member ID is going to be key for counting claimants and using for, linking to member months data. The claim dates are kind of self-explanatory. I'm using two key dimensions in our Streamlit app, which you'll see later. And I've pulled in a bunch of other dimensions that are just ways that you can slice and dice the data in a deeper way. But we didn't actually put that into the Streamlit app for a couple different reasons, mostly due to performance in Streamlit at this point. But I'm using diagnosis code, and then this DXCCSR category is like a very high level category that ties to diagnosis code. For those of you that aren't familiar with the AHRQ CCSR, and I forget what, I think it's chronic condition. What's the S stand for, Aaron?
I think it's clinical classification software refined, because it's like their V2, so that's what refined is.
Yeah. So this is high level, and I actually pulled this in, but I don't use it because it's too high level. It's like too much stuff falls in another bucket. So I actually use this CCSR category level 2, which is a little bit more granular. I think it breaks into maybe 60 or 70 different, maybe 50 categories. And then I use our encounter type, which is a granular grain encounter. You can think of it as service category, but like I said before, it's pulling in professional and institutional components into the same sort of category. And then we actually have a service category grouper. I didn't use that, but I wanted to be able to look at it if we wanted to. Same with DRG. Sometimes you want to look in more depth in DRG, revenue center. All of that you can pull in, and it kind of blows up your table. So there's performance considerations with all of that. But I brought all of that in because I could be interested in it. And then I also brought in rendering ID, which is probably not necessary, but you can also bring in like provider information and do this level at the grain of providers and look at like provider specialties and stuff like that. So it's a pretty basic medical query, and there's not much more that needs to happen. One other thing I'll say is I pulled in the condition categories for the primary diagnosis code to keep this analysis fairly simple. If you wanted to look at like all diagnosis codes on a claim, you could do that, but there would be some manipulation that you'd have to do, which I'm not going to get into here. So the idea is to kind of, you could manipulate it, and you'd have to get it in basically this structure anyway, and it'd probably blow up your table. There's some complexities around that you can handle. For any of this, just as a quick aside, if you have a specific use case and you're like, oh, this code would be great, but I have this specific problem, we have office hours, like we've put in the general channel a couple times, where we basically publish a calendar, and it goes to like Coco and I. And if you book time with us, you can just book any time that works for you for a half hour. We're happy to meet, bounce ideas off with you. And we'll try to bring in the right members of the team if there's specific expertise needed. So you're welcome to do that at any point. So if coming out of this, you're like, oh, I'd really love to like adapt this, feel free to do that. I'm going to skip pharmacy. I pulled a pharmacy, like I also did a pharmacy claim query that's basically the same structure as the medical claim query. Because sometimes you have pharmacy data. The LDS data that we have doesn't have pharmacy data, so for time's sake, I'm going to skip it. So there's a medical claims query and a pharmacy claims query, and then I pull them together into the same big data set with a bunch of pharmacy-specific dimensions that I'm nulling out, essentially, and then the same with the medical. So that's what that query does. And then I end up with this big, highly granular query full of all the members in the LDS data set. And this one takes a while to run. Against, if you have a big data set, this is pretty big. But I pull that all into this big wide data set called all claims. But then I'm actually going to pull it into like BI tool or somewhere else, and I might not want to analyze everything all at once. And so, for example, I didn't want claim lines in there. They're not analytically helpful. So I think this is a key step that's worth spending a little time on. The key here is you want to keep all the fields in your query that you want, and I'm not going to get into that in depth, and then you define your metrics down here. So I want to analyze paid amount. I also want to count members and utilization, which you might be tempted to do here in this query, where you're sort of to pre-aggregate. In BI tools, that can be complex. So if you're going to if you know already what you want to analyze, so let's say you want to count encounters. A pretty standard way of doing that would be to take encounter ID and do it, just basically count distinct encounter ID, and then you'd have a table with all these dimensions and the encounters for each of those members and claims, like the number of encounters that are represented. And then you'd be tempted, you could sum that up and it would sum to the total. But then when you start slicing and dicing by these dimensions, summing across starts to cause duplication issues. And so you actually probably want to save that count distinct. It's the same way of counting encounters for later, depending on what you want to do. But paid amounts sum pretty smoothly, so that's what I'm doing here. So this table I'm calling all claims egg or aggregate, because I've aggregated it up to a higher level. I've gotten rid of some of the detailed fields that make the table very long. And so that's the core set of queries. You can use this set of queries to do pretty much any type of cost and utilization analysis by pulling in different dimensions, only the ones you need, all the ones under the sun. And I'm pretty sure many of you have done versions of this before. But the reason I wanted to spend some time on this is because you could basically take this code, point it to your Tuva instance, change the schema if you have a different schema name or something, and pull this data. There are a few nuances, like our LDS data was run on a previous version of Tuva that split out MSDRG and APDRG, for example. So there are some nuances here, but basically this set of queries up till now you can use to identify any cohort of members and basically structure your data in a way that's very helpful later on to put in like a BI tool or whatever. The next step is, and this is the one I really cleaned up and annotated because it's a little bit complicated. This is the query where I'm only interested in outlier members. So I need to do a step where I define outlier members, I like flag them, and then I'm going to subset the claims data set, claims ag, and the member months data set that I pulled to only that cohort that I'm interested in. And so that's what this query is doing. It's doing a couple things. It's going to aggregate to the CTE right here, aggregates to a subset of members by year if you have multiple years in your data, which I don't, but in our example data we do. And it's going to basically sum the paid amount so that we can identify a outlier threshold and basically put a flag on any member that has a cost in a given year that's over a certain threshold. So that's what this first CTE is doing. It's just creating a data set that's very small that has, member ID, incurred year, and the total paid amount for a given member in a given year. This data is so big that it was breaking everything. It was like millions and millions of rows. And so I actually had to subset the 5% sample of all Medicare members to a 2.5% sample, which I think resulted in a claims data set that had like 4 million rows. The results, I checked the results. So I did the full data set analysis and in like Tableau, and then the sample that I pulled, the results are almost identical. So I pulled a random sample just for performance purposes. You do not need to do this, but if you want to, I'm happy to help think through it if you have very large data. The next thing, there's a couple, this is just a step that does some pre-aggregation at the population level, because as you'll see in the dashboard that I'll show momentarily, there's some summary statistics. So I'm not going to go into that further. I've really beat this to death. The key component here is setting the outlier threshold. There's a bunch of different ways you could do this. You could take the top 2% of people, the top 5% of spend, the top percentile. I chose to do kind of the statistical outlier rule of thumb, which is 2 standard deviations away from the mean. So we calculated the mean, and then 2 times the standard deviation. It basically creates a column in the data set that has for each member basically the outlier threshold for that year. So you can compare their total paid against the outlier threshold, and then we flag them as an outlier or a non-outlier. Pretty
so
straightforward.
Paul, you're basically computing each individual member's PMPM. Exactly. And saying across all of those, so then you have a statistic essentially for every member. And then you're saying, let me look at the distribution of that. What's the average of that? And give me 2 standard deviation, or I guess maybe it'd be the median. And then, or two standard deviations away from whatever that number is.
Yeah,
Okay.
except in this specific example, I'm actually using absolute dollars because I don't need to standardize it.
Oh yeah, yeah.
You could standardize it, would give you theoretically the same results, but it'd just be a bunch of extra steps.
One question that Ian asked a little bit ago, and I was waiting for maybe a better time to bring it up, but I think it's a good question, and I don't know if you cover it in this, or this would be a future thing, but the factor of, are you taking into account here anything related to continuous enrollment? Ian says sometime, or even like less strict, like sufficient enrollment. In the past, I've found PMPM cost outliers frequently come from very short enrollment spans, either due simply to denominator issue, but also extreme health events.
I did not do that here. And primarily the reason I did it is I'm looking at this through a value-based care lens, in which case you're accountable for all those costs. So I would actually be interested in analyzing them. Yeah. But in like past, like if I was evaluating the impact of a program or something where you actually had to have like members who had enough time to be impacted by your clinical management program or whatever, I would probably do some sort of continuous enrollment threshold, or at least try to understand and deal with any, members that had extremely short stays and maybe not enough time to be impacted. So I did not do that here for a specific reason, but it's definitely valid depending on your use case.
Yeah, makes sense.
So the rest of this is pretty simple. This data set basically flags members as outliers or non-outliers in a member ID. And then pretty much I join that table back to the two data sets that I created, the claims data and the member data, and only keep the outliers. And I end up with two smaller data sets for my cohort, in this case, outliers. You could do this with any condition. You could identify people who had any cancer diagnosis, or people who had back surgery in a given year. There's just any number of ways that this works. And so that's the query, basically. I did a couple validation steps here at the bottom because I'm going to move this into a BI tool, or in this case, a Streamlit app. And I just wanted to validate, like, okay, I want to calculate the number of members, member months, total paid. I calculated PMPM from that sort of manually. I don't know if I have these tables built and this will run quickly. Say it won't, so I'm not going to get into that. But I validated that the numbers match, so that I had an anchor. And you can call these control totals or whatever you want, but it's a good idea at the end of your query, if you're going to move to some other, whether you're going to put it in a Python notebook or do something else, that you're not dropping data, or that everything sort of aligns in your tool. So that's what that step does. I'm going to stop here with the query demo, and we'll pull up sort of just in time with the Streamlit apps. I did want to recognize a couple folks. So I'm not a Python developer. I actually started this out in Tableau. I pulled it into Tableau, and Tableau is really great if you want to like be able to set up a drillable dashboard and all of that. It's not so great if you want to open source something. So what we wanted to do is create like an analysis that you would do, but actually give you a blueprint for doing it, and sort of give you the ability to, like, if you run this query and you create a couple of CSV files, we're going to publish this into our GitHub repo, and you can go clone the repo, put your CSV files in here, follow our instructions, and pull up this same Streamlit app yourself, and then make any edits that you want. So the idea is that the great thing about the Tuva model is this standardized model that we're all using. We should be able to share analyses. So if you have ideas or improvements to make on this, this will give us a venue for doing that. And I also just wanted to recognize a couple individuals. Let me fix my camera here. Who helped with this: Sagat Gemayer. Sagat, apologies if I screwed up your name, and Rajat Sharma from our partners at MyTree, who helped us with the development here. So I just wanted to thank those guys. Everything you're about to see is from them. They took my, Tableau, a couple of images of my Tableau dashboard, and spun it up into this great Streamlit app. So thank you very much to that team and those guys. Okay, let me pull up the final component here. So this is the Streamlit app. I have two versions of this up. Lost. Here we go. Sorry. Two versions. So this is the version. If you go clone this repo and you run the Streamlit app, and there's instructions there, and we're happy to help, and we'll try to make it clear. But if you ever have trouble, just reach out on the Slack channel and let us know, and we can troubleshoot. But this is what you'll see. Basically, you run the app, and it pops up in a browser, and you have basically 3 pages to the dashboard currently. We can expand on this, or you can expand on it, or whatever you want. And there's going to be a filter here to toggle between different years. And this is run against, I think, I can't remember if this was CMS synthetic data or our Tuva. I think it's our Tuva demo data, which is basically a synthetic sample of data that's like 1,000 members or something. Actually, in this case, maybe 800 members that we actually identified with. So it's probably more than 1,000. In any case, I'll walk through these views. So this view is something I would typically want to do. I did this when I was at health plans, when we were reporting on populations like an employer group or our ACA population at Bright Health. We created a whole dashboard for this for all of our different markets. At Teladoc, we didn't actually do analyses in this way as much as we wanted to, but you're basically setting the context. And so it's really difficult to look at, a view like this and get an idea of what's going on if you don't have a context for who the population is. And so I think I always find it very helpful to put some of these key statistics right at the top of the page. So in this example, we can see there's relatively few members in this specific population that actually met the outlier status, 122. You get some other statistics here. I'm actually not going to go through this one. I'm gonna toggle over to the real data. So this is demo data, and there's these views. This cost driver, then looking at it by encounters, and then by diagnosis. And I'll walk through these, but I want to use real data because it's just more interesting and more fun. So this is the 2020 LDS population. 2.5% of the 5% sample. So, this is just kind of a random sample, but it aligns almost perfectly with the full population. There were 30,000 members. Half of them were female. So this just gives you a quick idea of the distribution. And after you look at a bunch, you can tell oh, there's more females here and maternity costs are higher, but this other population had fewer. You can get some context that way. Mean age is 77. Again, I haven't looked at enough of these to kind of put that into context, but it's really helpful to have the context. Sometimes people know, oh, that's a really high mean age. So, that might be a reason that you're seeing higher costs. Aaron brought this up to me. I know intuitively what HCC risk scores are and mean, but I haven't looked at them very much. And I certainly haven't ever looked at them for an outlier population. So I didn't know if the average HCC risk score would be 20 or 2 or what. So this just gives me an idea okay, the average risk score for this population is 5. I think the idea behind HCC risk score is that it should be near 1 for a given population. That's sort of the goal, but I didn't standardize this, so that's possibly why. And then you have the total paid amount. And then here the paid PMPM calculated in the way we talked about. And this is helpful to anchor to. So $9,700, which is pretty high, but not unexpected for a Medicare outlier population. And then the other thing that I also included encounters per 1,000, which kind of means not much here because it's all kinds of different encounters. So you can have DME encounters, which is just a claim for a DME probably, but you can have professional visits and inpatient admits and all those. So this isn't as helpful until you start breaking it down, which we do. And then your cost per encounter. But it's helpful to have an anchor for that stuff anyway.
Not to rush you. This is great, Paul. Not to rush you, but we probably got 3 minutes or so to wrap. Yeah. Time flies when you're having fun.
Yeah. The rest of this is self-explanatory. I won't go through this page anymore. I like to look at these things through two lenses. Encounters, or just like a service category. What was done? This is unsurprising. It should surprise none of you. And without a condition filter, this page is actually not that interesting. That's a thing I want to add before we publish it, and I just didn't get time. But inpatient cost, as you would expect, is the highest. Outpatient. The nice thing about looking at it this way is I have the other two metrics here. So it's like, oh, well, what was like the main driver of inpatient costs? There's 4,000 visits per 1,000 member. I don't know if that's high or low. It's probably a little high. And, you know, it costs about $20,000 per inpatient visit. And again, I don't know if that's high or low, but it's probably in the ballpark. And then by condition. So this actually was the thing that teased me up for the next iteration of this. A lot of these things are the types of things you'd expect. In 2020, you'd expect to see COVID-19, chronic kidney disease. There's a bunch of companies out there trying to solve this problem. Anti-neoplastic therapies, that's, you know, cancer treatment, so that's not unexpected. Septicemia is at the top of the list, and that is not surprising to me, but one of the things that I noted here is septicemia, I've not heard a lot about solutions to try to mitigate it. I know hospitals care about it. So I'm actually curious and want to drill down into septicemia, but that wasn't the main goal of this analysis. The main goal was to showcase doing an analysis like this in Tuva and to give you a tool to like quickly identify outliers for whatever population you're looking at and say, oh, maybe we should look at carving these out or whatever. So I'll conclude there. And I'll kick it over to you, Aaron, for any questions. And apologies for not leaving enough time for questions. Lesson learned. We either need more time or I need to talk less.
There are a few questions, but we probably have to wrap.
Yeah.
I would just say let's move any questions over to Builders Ask in Slack, and we can just follow up async there. And then if any kind of individual question gets a lot of people, we can kind of spin up like another, like we can find like, 30 minutes like in the next week or something to do a deep dive on that topic. So this was super awesome, Paul. Thanks for putting it together. I thought it was a really interesting talk.
Thanks, everybody.
Yeah, we'll see y'all later.